Hi everyone, I'm Jaden Hattery and I am an MD MPH student here at the College of Public Health. I'm presenting on pediatric asthma, which is a common condition that in my clinical experience is often not taken as seriously as it should be. So, what is asthma? It's a chronic condition that causes wheezing, coughing, and difficulty breathing, which can result in permanent lung damage and death. The cause is unknown. Patients often have triggers such as common allergens like dust or pollen, physical activity, stress, or even anxiety. According to the CDC, 1 in 12 in the U.S. suffers from asthma, which totals 6 million children. More than half with asthma had an attack in 2016, and 1 in 6 visits to the ER yearly. 1 in 20 end up hospitalized yearly. From 2016 to 2018, the mortality rate was 2.7 per million in the U.S. The highest rates are in the Midwestern U.S. and large metropolitan areas. Although the adult mortality rates have statistically significantly decreased since 2006, the child mortality rate has remained stable. The medical costs associated with care for pediatric asthma in the U.S. are estimated to be $600 million per year. Controlling inhalers are often extremely expensive and can be impossible to afford, especially for families that do not have health insurance. Some debate still exists, but it has been proposed that viral infections with respiratory syncytial virus or RSV and genetic polymorphisms can contribute to development of asthma. A vaccine for RSV is currently undergoing clinical trial, which could potentially be a great option to prevent asthma from ever occurring. Studies have shown that for infants with multiple risk factors, such as family history of allergies and high levels of IgE, administration of an antihistamine is associated with a minor risk reduction in development of asthma. More studies are required to demonstrate this risk-benefit relationship further. Asthma action plans are made by physicians in partnership with their patient and their guardian, listing what medication should be used in each zone and how often. Specific descriptions are typically provided to identify each zone further. This ensures seamless communication between school nurses, daycares, and parents. Black non-Hispanic children are the most likely to be diagnosed with asthma. Asthma deaths in Black Americans is higher than any other race at 28.7 per million. This is likely related to factors of systemic racism in our country. An article published in the Journal of Allergy and Immunology in 2021 titled Housing and Asthma Disparities discusses that housing conditions are often the most important social determinant of health for asthma. Historical redlining practices led to disproportionate impacts on people of color. This is a cohort study in which 30 primarily Black families with children ages 2 to 17 with asthma had home inspections and repairs of potential asthma triggers. In the year before repair, 90% of children had gone to the ED for asthma and 86% had an overnight stay. Services conducted include removal and prevention of pests such as cockroaches and mice, mold-related wall, roof, plumbing repair, removal of carpet that can harbor dirt and dander, and installation of dehumidification devices and exhaust fans. Qualitative data collected included a survey of homeowners after repairs to address their thoughts of the program. The majority of negative feedback was that repairs of non-asthma related things were not addressed and that they did not have much say in the things that were done to their own home. Quantitative data was used to demonstrate reduced hazards from the homes and improved health outcomes of the children with asthma who lived there. There was a significant reduction in cockroaches and rodents within the homes due to this project. There were 20% reductions in nighttime awakening, rescue inhaler use, disruption of physical activities, and parents missing work in the year after the program. Children missed school 41% less days than they did prior to the repairs. These were pretty significant results. So reductions in factors meant to assess asthma morbidity were extensive. Unscheduled clinic visits were reduced by 35%, emergency visits were reduced by 73%, and overnight stays were reduced by 82%. So time, money, and stress were reduced by this program. The change in symptoms and healthcare utilization between the groups was not statistically analyzed for significance. That made the data less powerful. The program would be challenging to implement on a widespread basis due to the funds required to help multiple families with these large-scale projects. The CDC created a national asthma control program in 1999 with the goal of reducing morbidity and mortality. Currently, 25 public health departments are funded by the CDC to address the burden of asthma from a financial, quality, and governmental policy standpoint. Improving transparency of drug prices and creation of generic asthma control inhalers can decrease costs for families. Increasing funding for home repair for needy families can decrease the trigger exposures. Increasing child and guardian knowledge of asthma can improve the avoidance of triggers and also improve medication compliance. No child should die from asthma, By continuing to plan, implement, and evaluate programs to address health inequities for pediatric asthma, we can decrease morbidity and mortality associated with this condition. And then the next couple slides are just my references, so thank you so much.